And bronchoalveolar lavage, we're all familiar with the bronchoalveolar lavage and how to perform it with the aliquots of 50 to 150 ml. And of course, we retrieve only about 30 to 50%. And the quantitative cutoff is 10 to the power 3 as a colony forming units. First sample to be discarded, and then the sensitivity, as we all know, is 73%, and specificity 82%. Transbronchial lung biopsy, we have to take care if the patient is on mechanical ventilation to avoid any problem of pneumothorax, etc. So it should be, literally, should be very cautious about doing transbronchial biopsies, especially if the patient is on mechanical ventilation. But we can use, of course, the fluoroscopic guidance as well. Therapeutic bronchoscopy is very important, and it's we perform it in the ICU, especially for the asphyxia due to a foreign body inhalation, mechanical removal of tracheal tumors, etc. If we have the laser as well to debulk the tumor, and that's the carbonization, that's a foreign body, etc. So it's important to have a rigid bronchoscope because we face in our intensive care a lot of cases having foreign body inhalation. Rigid bronchoscopy should be one of our armamentarium in the management of, especially in foreign bodies and for debulking major tumors. So it's one of the major practice we perform in our unit. The technique of non-invasive mechanical ventilation, we can perform as well fiber optic bronchoscopy through a port of entry if the patient is on non-invasive, and we can introduce the fiber optic, and the patient is as well on a CPAP. We can as well do the bronchoscopy if the patient is on an venti mask, but we have to have a cut here or a hole, and we go through the nostril to have the specimen and biopsy. So this is another technique we can perform in the ICU. Sedation is very important, other conscious sedation. Adequate sedation is important, anesthesia, etc. We use usually the propofol with an anesthetist, and it helps a lot in saving a lot of time instead of the local anesthesia. But of course, we can perform as well local anesthesia. The precaution should be remembered by all the staff. We have a guideline, and it's international. Blood pressure, the antihypertensive drugs should be continued. We have to understand that oral antidiabetic insulin should be omitted the day of procedure with pre and post procedure control of serum glucose level. Before biopsies, we should have the platelet, PT, PTTs, creatinine, fiber optic without biopsies. You have to have the platelet count, which should be more than 50,000. If we have an acute myocardial infarction, please don't go with a bronchoscopy except after 6 weeks. And the food should be omitted 6 hours before the procedure. Platelet count, as I just mentioned, should be more than 50,000. If we're going to perform biopsies, should be more than 75. Plavix should be omitted 5 days before. Warfarin, the INR should be less than 1.3 and stop 3 days before. We can shift to subcutaneous heparin. IV heparin, if it's more than 2 hours, we have to check the PTT. And the anticoagulation, if they are necessary, we can switch to the fractionated heparin, or the INR should be less than 2.5, and heparin should be started, fresh frozen plasma should be available with the vitamin K. So it's important to remember this data. ABG as well should be done. FEV1 should be, if it's less than 40% and saturation is less than 93%, we can postpone the bronchoscopy except if it's an emergency. If he's inhaling a foreign body, etc. So we go, but we have to take care. Sedation should be as well. Remember that if the patient is having COPD, etc., remember that high flow oxygen can produce CO2 narcosis. and bronchodilation should be done, performed before the procedure if the patient is asthmatic. Indications and contraindication, the most important thing is to have a good practice. If you don't perform bronchoscopy, you should have assistance, or you should know how to do it, and you can induce a lot of risk to the patient if you're not familiar with the procedure. So this is very important for those starting the practice. This is one of the indication, a lot of secretions and were aspirated, and collapse of the lung, and if you aspirate it, the lung re-expands. It's one of the indication, even to collect some specimen. If the patient is having pneumonia, etc., we can collect specimen by the bronchial lavage or bronchoalveolar lavage. As I mentioned, we have to take care of the transbronchial lung biopsy in the ICU ventilated patients. We have to take care, and we can, if he's on ventilation, you can, as I mentioned, he can develop a pneumothorax. So please take care, and usually we don't perform the transbronchial lung biopsies on mechanical ventilation in our unit. The management of hemoptysis, of course, is important. If it's a major hemoptysis and major bleeding, we have to introduce a rigid scope. Or we can do with a Fogarty, with a fiber optic through an endotracheal tube, we can manage the bleeding, etc. It can help as well, the bronchoscopy can help as well in the verification of the proper endotracheal tube or double lumen to detect is it in a good position or not. So it's important to evaluate this with the bronchoscope. And those performing the dynamic stenting, the wide stent, you need as well to have a bronchoscopy to see if it's well positioned in the system, in the tracheobronchial system. So my conclusion is flexible bronchoscopy should be essential piece in the ICU facility. It's proven useful for a wide range of respiratory diseases in critically ill patients, easy to achieve at the bedside. It's a very easy procedure, but you have to be trained. It needs careful preparation and close monitoring in selected patients with few relative contraindication, and it should be performed by experienced bronchoscopy. Thank you very much.
Dr. Safat, thank you very much for this elegant and brief talk on bronchoscopy in ICU. Our second speaker is Dr. Aleš Rozman. He's my dear friend from Slovenia, Golnik, Slovenia. He's the director of Interventional Pulmonology Unit in University Clinic of Golnik. I have known him for the last 6 years. He's preparing and doing courses on interventional pulmonology every year in Golnik. That's how I got to learn him. Aleš, podium is yours. Let's hear about cryobiopsy, bronchoscopic cryobiopsy.
Thank you very much, Semra. Dear colleagues and dear chairman, thank you very much for inviting me here. It's a big honor and pleasure for me to talk here. The topic of my talk will be bronchoscopic cryobiopsy. And for the very beginning, I show a little bit, show a technique a little bit in several minutes. Then we'll go to the studies and to the data which were published so far from this field. So the mechanism of action of cryoprobe is basically very simple. We have a compressed gas, and when we release this gas at the tip of the cryoprobe, this gas rapidly re-expands and cools down the tip of the probe. This cold is then transferred to the surrounding of this probe, and according to this, we can do several things into the bronchial tree. The effect is called Joule-Thomson's effect, and you can see it here on the scheme. Gas is at the tip rapidly re-expanding and reaches, in the cases of nitric oxide or CO2, which are most commonly used gases for this method, they cool the tip of the probe to around -80 degrees of Celsius. And we see, if we put the tip of the probe into the water, a small ice cube or a small ice ball is formed around the tip of the probe. So if we put this probe into the tissue, something similar happens in the surrounding of the cryoprobe. So the tissue in direct contact with the cryoprobe is frozen, and with the distance from the tip of the probe, there is less and less and less cold. Usually we get an area of approximately 5 millimeters or 6 millimeters of frozen tissue, and on the with the distance is tissue just cooled, not frozen. So if we see a little bit further, I also show the equipment. We see that the equipment is pretty much simple. We have just a bottle of compressed gas, which is either nitric oxide or CO2 for medical purposes, and a small controller device. This is cryoprobe, which is attached to the controller device. And when we activate the probe, the gas is pushed into this catheter in the controlled manner, and the tip of the probe, which is this, is then cooled, and we are able to have some effect with this in the tissues. At the moment, we have, at the market, we have two dimensions of cryoprobes. One is 2.5 millimeters in diameter, and the other is 1.8 millimeters in diameter, and they both fit the working channel of the flexible bronchoscope with the wider channel. So what are the applications of the cryoprobe? We can use the cryoprobe for cryotherapy, which is not the new thing. We use the cryoprobe for endobronchial cryotherapy for several decades. First, just for cryotherapy, for freezing the tissue and removing it several days or even a week later. The newer method is cryorecanalization, when we just extract with the cryoprobe pieces of necrotic tissue. And also there, we can also use the cryoprobe for cryo-extraction, when we have some foreign bodies which are on the water basis, like organic foreign bodies. We can just attach the cryoprobe to them, froze it, and remove it en bloc out of the airway. But I want to talk about cryotherapy today. The most important thing which I need to answer today is cryobiopsy. We have several types of cryobiopsy. We can either biopsy inside of the bronchial tree when we see the tumor or a nodule or perhaps a granulation tissue, or we can make a transbronchial cryobiopsy in two occasions. One setting are nodular lesions or perhaps tumor or round lesions. The other are diffuse parenchymal lung disease. We can also use even cryobiopsy in thoracoscopy and take cryobiopsies from the parietal pleura, but this is beyond the scope of this talk today. First of all, I will talk about endobronchial biopsy. The first report was published 7 years ago, and it showed that it is feasible, that the samples are big. And slowly after that, 2 years later, there was the first study compared forceps biopsy and cryobiopsy. Diagnostic yield in cryobiopsy was around 15% higher than in forceps biopsy, and it found, authors found that statistically significant, and the method is good for using it for endobronchial biopsies. But the most important study was published in 2012 by a German group. They made a randomized, multi-center group of blind pathologists were involved in this. They include a large number of patients. They recruited 600 of patients, and most of them were randomized into groups, either for forceps biopsy or for cryobiopsy. So let us see the results a little bit. Here we can see that in the majority of the cases, the material was diagnostic in both groups. So in the forceps biopsy, the diagnostic yield was around 85%, but in the cryoprobe group, the difference was 10% higher. So this was found to be statistically and also clinically highly significant. Then authors compared exophytic tumors, that are tumors with tumor granulations inside of the bronchial tree, with submucosal tumors, which are just changes without direct connection with the bronchial wall. And they found that in both groups, cryobiopsy is more successful, here 97%, here 90.9%, than forceps biopsy. Of course, we should suspect that in submucosal tumors, the diagnostic yield will be in both groups a little bit lower than in the exophytic tumor, but still not so much difference between these two groups. So the conclusion of this very powerful study was that the forceps biopsy is inferior to cryobiopsy in the case of endobronchial tumors or changes suspected for endobronchial tumors. And also very important thing is there were no significant bleeding in both of groups. of course, we can see that in the group with cryobiopsy, there is a little bit more of mild bleedings than in the group of forceps biopsy, but the difference was not big. And of course, in the group with known bleeding, the forceps was leading in comparison with cryoprobe. That was statistically significant. But the most important is that severe bleeding was not more often more common in the cryoprobe group. So the conclusion of this study was that cryoprobe is superior, cryobiopsy is superior than forceps biopsy in the case of suspicion of endobronchial tumor. The second thing are transbronchial biopsy for peripheral pulmonary lesions. So far, only one study was done on this field from the German group. They included patients with peripheral lesions up to 4 centimeters in diameter. The technique was using general anesthesia and rigid bronchoscopy. Through the rigid bronchoscope, they inserted a flexible bronchoscope, and in randomized way, they biopsied the peripheral lesions. First of all, they used the EBUS mini probe to localize the lesions. Sometimes, if doctors need this, also use the fluoroscopy. When they identified the lesions, in half of the patients, they took samples with forceps first, and then with cryoprobe, and in the half of the patients, opposite. They used also the guiding sheaths in all the patients, and they used both methods in random order. So the number of patients which were included were pretty small. They were 39 recruited, 38 were then randomized in this way. In 7 cases, the lesion was not reachable by EBUS, and in 31, it was positive, and they were able to make biopsies either with forceps or cryoprobe. The study is small, and it's basically a feasibility study. I'll show also results at the end, but they suspected that cryobiopsy should be more successful in the case of type 3 lesion, where we don't have a bronchial sign, like in these 2 cases when the forceps biopsy is very effective, but we have a bronchus who goes around the lesion, and when we want to take biopsy with the forceps here, we are not very successful in most of the cases, but cryobiopsy can also take sample laterally because it freezes all the surroundings, and they suspected that in this scenario, the cryoprobe would be a little bit suspected. So it was confirmed that this is true. The cryobiopsy samples had a little bit higher diagnostic yield than these white columns, which were forceps biopsy, and that diagnostic yield was not so much dependent on the number of the samples. Of course, it goes a little bit up from the first to the second, but from the second and the first sample, the diagnostic yield is basically almost the same. Overall, diagnostic yield was 60.5%, which is in the range of all studies with peripheral pulmonary nodules. They were able to reach around 3/3 of the lesions with EBUS, and within the lesions where they were reached with the EBUS, diagnostic yield was 74% in the whole group. Forceps biopsy was a little bit less successful than cryobiopsy, but the sample is small, so the statistical difference here is not important. But they noticed that the samples are much bigger in the cryobiopsy group than in forceps biopsy. And there were no serious complications, no pneumothorax, just one moderate bleeding in one of the patients. Maybe the most intriguing thing, or maybe most new thing here, are the third type of biopsies. These are transbronchial lung biopsies for diffuse parenchymal lung disease. So here is maybe a little bit complex algorithm of diagnosis of diffuse parenchymal lung diseases. In the recent time, the importance of good diagnosis is more and more important since the new drugs are coming and the patients are needed to be diagnosed in a precise way that these patients could be included in some studies, especially with pirfenidone, nintedanib, and some new drugs are also coming for interstitial fibrosis or diseases, idiopathic pulmonary diseases with fibrosis. According to the guidelines which are still in use for 2013, the major thing when we exclude all these upper reasons is high-resolution CT scan. if we found the typical pattern of usual interstitial pneumonia and fibrosis on high resolution CT scan, the patients can be treated or evaluated without invasive procedures. But when these results are not conclusive, we shall use one of two types of the biopsy. One is a bronchoscopic biopsy, the other is surgical biopsy. When we have suspicion that we have sarcoidosis or some of this group of disease, we use bronchial biopsy, bronchoscopic biopsy, but surgical are in the cases of non-specific interstitial pneumonia or dyspneumatic pneumonia. Bronchoscopic biopsy has several advantages. One is that it's not very invasive, that the patients can be done in outpatient basis, or also very sick patients can do that on this. It has a good diagnostic yield when we have alveolar ossifications, paralymphatic distribution, and bronchial sign and so on, like in sarcoidosis and alveolar proteinosis and so on, but have several disadvantages. They are very low. They have very low sensitivity for usual interstitial pattern and very low specificity for non-specific interstitial pneumonia and desquamatory interstitial pneumonia. And the diagnostic yield is very low in these cases. On the other hand, we have a surgical lung biopsy, which is more invasive and has much more complications than bronchial biopsy, but also a higher diagnostic yield. Mortality is 3 to 4%, but in the group of the patients with usual interstitial pneumonia is even higher, because in many patients they saw acute exacerbation of the disease following the surgical procedure. Where to put this cryobiopsy? Okay, so at the moment we don't have enough data to put it really here between conventional transbronchial biopsy and surgical biopsy, but it seems that it fits somehow in between. It is in direct comparison with conventional or forceps biopsy is much superior, but at the moment it doesn't reach the diagnostic yield of surgical biopsy. But the main aim of this biopsy is most probably to replace the majority of surgical biopsy with bronchoscopic biopsy in order to reduce the invasiveness of procedure and to reduce the number of the complications. So far, in studies published, only one patient died in one study, so this percentage is maybe a little bit lower. It's taken just from one study, not from the meta-analysis, which is not done yet. I will show just two studies here, which are most interesting. The one is from Italian group. It's a prospective study. They just wanted to test a transbronchial lung cryobiopsy for the diagnosis of fibrosing diffuse parenchymal lung diseases, which were non-diagnostic after high-resolution CT scan, in order to possibly avoid surgical lung biopsy. 63 patients were done, and included. And what's interesting in this group is there were very high percentage of patients with usual interstitial pneumonia, 75% in comparison with other diseases. So characteristic of this study was that they found that the transbronchial lung cryobiopsy is safe, diagnostic yield is pretty good, that there's good agreement between pathologists which blindly observed this, examined these samples. And characteristic was that there was a lot of patients with fibrosing disease, and they took biopsies very peripherally from the vicinity of thoracic wall, because in the 1/3 of the cases they found parietal pleura or visceral pleura in the sample, and in additional 30% interlobar septum. And they used the Fogarty balloon in all the cases just as a prevention of severe bleeding. They didn't find any severe bleeding because they used Fogarty balloon. They weren't even able to detect it, but high rate of pneumothoraxes, which were directly connected with the parietal pleura in the sample. One patient died because of exacerbation of interstitial pulmonary fibrosis 7 days later. The other study is from Barcelona group. This is the first group which compared directly the forceps biopsy with cryobiopsy. They recruited 77 patients. In one group they made cryobiopsy, in the other group they made forceps biopsy. The results were like that. Histopathological diagnosis was done in 3/4 of the patients with cryobiopsy. In multidisciplinary group, in 51%, which is of course statistically very significant in comparison with forceps biopsy. In all these categories, cryobiopsy was better. And there was also, I will just skip this slide. I just wanted to show that the selection of the patient was a little bit different. There was a little bit more patient with non-specific interstitial pneumonia and not so much with usual interstitial pneumonia. The complication rate was acceptable. There were no grade 3 bleedings. The amount of pneumothorax was very low. I'll also skip this slide because I'm a little bit too late. According to this, I will just conclude that there are several unanswered questions before we implement this method to routine use. First of all is what technique of bronchoscopy, intubation, or sedation shall we choose, because in all these studies were different. Shall we use a blocker balloon? Which type of gas? What's the freezing time? Distance from thoracic wall? Number of samples? Sampling time? Same or different lobes or segments? And according to this, in the studies which were published already, the diagnostic yield is different. So for the conclusion, I will just say that endobronchial cryobiopsy is safe and superior to forceps biopsy. In the case of transbronchial cryobiopsy of peripheral pulmonary lesions, it is feasible, but seems promising, and not a lot of data are available. So here, further evaluation is needed. But in the case of transbronchial cryobiopsy in diffuse pulmonary lung diseases, it is safe, superior to forceps biopsy, but needs further evaluation, especially comparison with surgical lung biopsy at the moment, and it needs some standardization. For example, how many samples, where to take them, and so on. So thank you. I'm apologizing because I exceeded my time a little bit.
Thank you, Professor Alex. Thank you very much. You're available with us, so any questions will be during the coffee break or during the break. Thank you very much.
With the meet the expert also.
And we have a meeting, the expert at
It's 8:30.
8:30 in the evening. So you'll have a lot of questions. So let me introduce our dear friend and faculty member, Professor Semra. Professor Semra is a professor in the pulmonary department at Izmir University, and she is the president-elect of the European Association of Bronchology and Interventional Pulmonology. And she's a bionic woman.
Dear colleagues, dear friends, it's a great pleasure to be back in Cairo again. It became an addiction for me because this is maybe the 6th year I'm coming to the same meeting, but I enjoy it a lot. I'm saying it cordially, and I thank the organizing committee for being so friendly to invite me. This is going down. It's going down. Okay. In my talk on multifaceted approach to pulmonary nodules, I will try to concentrate on solitary pulmonary nodule management, but I will also touch to some issues in multinodular disease. As you all know, in solitary pulmonary nodule, the assessment of the number, size, and density is important. We should know that solitary means single. Whenever we see a nodule by itself, we should be sure that there are no additional nodules, no additional atelectasis, pleural effusion, or mediastinal lymph node. The size is important. If it's less than or equal to 8 millimeters, it's called subcentimetric nodule. If the lesion is bigger than 30 millimeters, it's no more nodule. It's the mass, and the malignancy potential increases. Density is important because we have 3 different densities: pure ground glass, pure solid, and mixed or semi-solid. The etiology and differential diagnosis of a nodule can be neoplastic, malignant or benign, infectious or inflammatory, vascular disorders, or miscellaneous such as intrapulmonary lymph node, rounded atelectasis, bronchogenic cyst, or mucoid impaction. When we are managing a solitary pulmonary nodule, the first thing is to assess the risk factors for lung cancer. How do we do it? We have to combine the clinical features plus the radiological features. And radiological features are, of course, by CT, thoracic CT. In this table, it's summarized very well, as you see. Nodule size and diameter, nodule characteristics, and the age of the patient, prior cancer history, tobacco use, smoking cessation, chronic obstructive lung disease, and asbestos exposures as clinical features. I won't go deep into detail for the sake of the time, but you have to combine the clinical features plus the CT features to get pre-test probability for lung cancer. You see here a very high possibility for lung cancer, spiculated or corona radiata border type. Lobulated border type also has high probability for malignancy. Smooth may be most of the time benign, but it's just an impression. You cannot be sure before getting biopsy. Usually they are benign. For diffuse calcified granuloma, you never go and take biopsy from this. You cannot, you shouldn't follow it because it's just permanent. Why did it go away? There is no need to follow up. Another benign nodule, granuloma with central calcification. Hamartoma is another one that is benign with popcorn calcification, fat density in a hamartoma, laminated calcification pattern in a benign disease. Again, these are not requiring any further diagnostic procedure. When we are mentioning about CT characteristics, I said density is important. In the last 10 years, studies on peripheral adenocarcinoma has shown that ground glass opacities or subsolid nodules have become important because they carry high potential for malignancy, especially pure ground glass solitary pulmonary nodules. As you see here, 2 pure ground glass opacities. Most of the time they are adenocarcinoma in situ. In the past they were called bronchoalveolar carcinomas or atypical adenomatous hyperplasia. They may grow slowly and show favorable prognosis, but in time they begin to grow fast and have a solid component developing. At that time they become invasive and need surgery. So we have to be careful with the semi-solid density. This schema shows, summarizes all the management for a pulmonary nodule, solitary pulmonary nodule. Here we have the observation threshold, and here the surgical threshold. Below the observation threshold, we can follow up the patient by doing careful observation with serial chest CT. And above the surgical threshold, we may go and do the surgery. And in between 2 thresholds, we have the intermediate possibility for lung cancer. On this side of the schema, you see the probability of lung cancer. When it's below 10%, most of the time it's careful observation. But if it's above 60 to 70%, there is high possibility for malignancy and surgery is needed. But is this so simple in real life? No. There are many factors affecting how you manage each particular patient. You cannot you cannot give a formula to manage a solitary pulmonary nodule in every single patient. It should be tailored for every particular patient. So, improved volumetric imaging decreases hazard of delay so that this observation threshold can be pushed upward. Patient preference, maybe patient is anxious and desires certainty, so the threshold is pushed downwards. So you do less careful observation. And on the other side, maybe patient preference is adverse to surgical risk and you don't do surgery, you delay it. And increased comorbidities and surgical risks of the patient may delay the surgery again. On the other side, we have very new techniques that decrease surgical risk so that pushes the surgical risk threshold downwards. In between, if we cannot do surgery, or if we want to do more tests, we have the intermediate probability area. We can do bronchoscopy, CT-guided fine needle aspiration, or PET. So I cannot give you a formula to how to do the management for a solitary pulmonary nodule. During careful observation, Fleischner Society consensus recommendations are useful. Here they give the size of the nodule and risk factors for lung cancer. I won't go deep into to the table, but here, for example, if the nodule is 4 millimeters and there is no lung cancer risk, follow-up is optional. If the nodule size gets bigger, 6 to 8 millimeters, and the patient has high risk for cancer, follow up at 3 to 6 months, then 9 to 12 months, and then 12 to 24 months if stable. If there's getting some difference or if it's getting bigger, of course you do further tests. So this Fleischner Society consensus recommendations depends on the size of the nodule and risk factors for lung cancer to decide on the frequency of surveillance with serial chest CTs. During careful observation, I repeat again, be careful with the ground glass opacities, semi-solid nodules, or pure or semi-solid ground glass opacities. So bronchoalveolar carcinoma, adenocarcinoma in situ, in other words, has a doubling time of 42 to 1,486 days. Such a variable doubling time. Don't be sure, it can shame you, especially nowadays. In the past, maybe we were missing them, but nowadays, we see more, maybe we catch more and more. So semi-solid nodules, pure ground glass or mixed, they should be followed up more than 2 years. Not 2 years, it should be 3, 4 years. Whether extended follow-up improves survival in these patients, it's controversial, it's debatable, but we have to follow them longer. In the diagnostic procedures, we have PET. We have to be careful with PET because it has false negatives, false positives. As you know, in adenocarcinoma in situ, mucinous adenocarcinoma, carcinoid tumors, it can be false positives. In inflammation and infection, it can be false positive. So PET can be useful when we are deciding to do surgery. Lymph node involvement and extrapulmonary disease can be shown by PET. But PET by itself does not show or characterize the nodule. It cannot show the details of the nodules. So when there is low probability of lung cancer, and if we use PET for this purpose, negative predictive value is high, and then you can observe the patient. But be careful with PET. If the nodule is small, less than 8 to 10 millimeters, then sensitivity decreases, so it can be post-negative. In diagnostic testing, we have CT-guided fine needle aspiration. As you all know, this diagnostic yield is high. There is risk of pneumothorax, around 30%, but chest tube requirement is low. There are some patient groups having increased risk of pneumothorax, but it's a good way of diagnosing. And then we have diagnostic testing, another diagnostic testing, conventional bronchoscopy. But when I say conventional, you have to use, for conventional bronchoscopy, fluoroscopic guidance. It is less accurate for peripheral lesions. The yield of fluoroscopy-guided bronchoscopy is low, 10 to 50%. If the lesion is small, it even gets less. And in the outer 1/3 of the lung, the diagnostic yield is less than in the inner 2/3 of the lung. When there is bronchus sign, CT bronchus sign, the diagnostic yield increases. Here we see different types of CT bronchus signs. This is cutoff sign. The bronchus is open to the tumor. Here we have the contained within the sign. This is the tumor is open to the bronchi. But in the third and the fourth one, the bronchus is not open to the tumor. In the third and the fourth one, you have to do a transbronchial needle aspiration to get a diagnosis. In the first and the second one, transbronchial biopsy, brushing, or bronchoalveolar lavage may help. But in all 4 of them, transbronchial needle aspiration reaches the tumor and you can get diagnosis. And a good clue in doing conventional bronchoscopy, combine multiple techniques to increase the yield. Washing, bronchial washing, brushing, and bronchoalveolar lavage do not have very high yields. But if you combine transbronchial needle aspiration with transbronchial biopsy, the combined diagnosis is 75%. Radial probe EBUS is a modern technique. In the last 5-10 years we are having it. The sensitivity is 71%, but if you use multimodality techniques, the diagnostic yield gets 80%. If the lesion is small, the yield is a little bit less, but not too different than when it's bigger than 2.5 centimeters. Specificity is 100%. Electromagnetic navigation is another diagnostic method for peripheral tumors or peripheral lesions. It combines bronchoscopy and CT imaging by using electromagnetic field. Diagnostic yield is similar to endobronchial ultrasound. Again, CT bronchosine increases the diagnostic yield, but look at here, yield of electromagnetic navigation plus EBUS is more than electromagnetic navigation or EBUS by itself. And the last sentence, yield of CT-guided transthoracic needle aspiration is much higher than the combination of EBUS and electromagnetic navigation. There's another new, very modern technique, but not in routine use now. There are two studies done on it, animal study and human study. It is bronchoscopic transparenchymal nodule access. Fiducial markers are placed using bronchoscope. CT software is used for entrance point, and then there is a virtual tract established from bronchus to parenchyma to lesion, and then there is a direct tunnel with balloon catheter, and you approach through the bronchial wall to the parenchyma and to the lesion directly. They say it's safe in the studies, but we will see. There are other techniques like hybrid EBUS with a 10-degree forward view we can use in peripheral lesions, and thin convex probe EBUS. It can go access deeper into the bronchial tree and has a 170-degree upward bending. And the smaller needle gauges do not disturb or do not decrease the yield of bronch. And there is another new technique. It's called navigation transthoracic needle aspiration. It's combining navigation with transthoracic needle aspiration, but there is no study done on it yet. Surgery, when we have high probability of lung cancer, of course we think about surgery, but not every patient can go to surgery. VATS, thoracotomy, or combination can be done for diagnostic and definitive therapeutic purposes. If it's benign at frozen section, wedge resection is done. If it's malignant at frozen section, then lobectomy and systematic lymph node dissection is done, and the mortality is low. I won't go again deep into detail, but if you have a nodule, a solitary pulmonary nodule, that is with benign calcification and is stable for the last 2 years. This is for solitary pulmonary nodules. If it's stable for the last 2 years and have benign calcification, there is no further workup needed. But if you cannot answer this, you have to assess the probability of lung cancer and assess surgical risk. And then you have to stratify patients into 3. Lobectomy risk low or average, lobectomy risk high, but lobectomy feasible, lobectomy risk is too high. Then you have to do, as I showed that schema, whether you have to decide on careful observation, whether doing some diagnostic procedures, or if there is high probability to PET, and if it's positive, surgery. In each category, you have to decide on these. And in the recent years, in 2013, ACCP gave this guideline for solitary pulmonary nodules. If it's less than 8 millimeters, follow Fleischner Society guidelines. If it's greater than 8 millimeter diameter, assess pretest probability for lung cancer, and then stratify patients into 3. Very low probability, serial chest CT. If intermediate, 5 to 60%, PET or PET CT. If negative, go and do serial chest follow-up, CT follow-up. If it's positive, you need tissue diagnosis or surgery. If it's very high probability, again, tissue diagnosis and surgery. For subsolid nodules, less than 5 millimeters in size, no follow-up is required. If pure ground glass, but if it's greater than 5 millimeters, follow-up at 3 months. If stable, follow-up at 1 year. If there is any change, you have to do surgery because you cannot do any biopsy in pure ground glass nodules. If it's part solid component, the probability of cancer is higher. Follow up with thin section CT in 3 months. If nodule is unchanged or has solid component that is greater than 8 millimeters, consider PET CT. Further recommendations are surgery, doing some biopsies, being more invasive. There are areas of uncertainty, impact of lung cancer screening and diagnosis of solitary pulmonary nodule. There is a study done, and it showed that death risk decreased 20%, but generalizability to practice is controversial or debatable. And also cost effectiveness of screening depends on the effectiveness of evaluation, and it also varies widely in reports. If I have, I finished my time, I can stop now. There are a few slides on multiple nodules. Should I stop or continue?
Would you like to tell those slides in the Meet the Expert? What do you think?
Okay, it's better.
So we have, by the way, we have a Meet the Expert, which would be a very important session this afternoon, this evening, from 8:30 to 9:30. We'll open all the discussion that will be in the meeting. You can show those slides during the Meet the Expert, Semra, because we are really short of time, you know. Thank you very much, Semra.
Thank you for Professor Semra for her excellent lecture. أتقدم بكل شكر والتقدير لأسرة جمعية الشعب الهوائية وعلى رأسهم أستاذنا الأستاذ الدكتور طارق صفوت والأستاذ الدكتور عادل الخطاب والأخ الفاضل الأستاذ الدكتور جمال محمد ربيع. والآن ندعو الأستاذ الدكتور محمد مصطفى متولي for his lecture named bronchoscopy, titled bronchoscopy in immunocompromised host.
بسم الله الرحمن الرحيم. طبعا في الاول بحب اشكر الساينتفك كوميتي وعلى راسها الاستاذ الدكتور طارق صفوت، الاستاذ الدكتور عادل الخطاب، اخويا الكبير الاستاذ الدكتور جمال ربيع على دعوتي، وطبعا شكر خاص للدكتور جمال ربيع على تحمله الام عمليه السيرفايكال ديسك من اسبوع وانه موجود هنا بينا. التايتل بتاع التوك بتاعتي will be about bronchoscopy in immunocompromised host. Actually, recognizing the immunocompromised host patient is an undergraduate skill, but we are certain that it is a postgraduate subject in dealing with. We have both infectious and non-infectious etiologies that may cause pulmonary disease in the immunocompromised host, and that clinical and radiologic features are often non-specific, so fiber optic bronchoscopy is frequently used as a primary mean for evaluation. We have the immunocompromised host is either congenital or acquired. We usually deal with adult acquired immunocompromised patients. These are immunocompromised because of the immunosuppression or because of the microbial infection, like HIV patients, malignancy, disorders in the chemical hemostasis like diabetes or uremia, autoimmune diseases like patients with rheumatoid arthritis or systemic lupus, and trauma like stress of pregnant women. But we have a net state of immunosuppression, and this is most important, is that we don't have usually one thing to make immunosuppression. We usually have a combination. For example, we have a neutropenia together with metabolic abnormality. After maybe taking the chemotherapy, the patient have uremia, have malnutrition, or even superadded infection with cytomegalovirus. So all these make a combination of causes of immunosuppression, which is called the net state of immunosuppression. The British Thoracic Society guidelines for bronchoscopy in adults in the year 2013 gave two main indications for bronchoscopy in our patients with immunocompromised. It was either if we have an infiltrate or something in the radiology and is not diagnostic, we cannot diagnose this by non-invasive techniques. So we do bronchoscopy with bronchoalveolar lavage to diagnose this, or the other indication, or the main indication, is transbronchial lung biopsy and lung transplant patient to diagnose rejection. These are some of the radiological features. If we have infiltrate like that in a patient, nodular infiltrate like that in a patient who is immunocompromised, we have the differential diagnosis that may be bacterial, like CAP, Pseudomonas, nocardia. If it's bacterial, if it's fungal, we have the Aspergillus, Pneumocystis, Cryptococcus. Mycobacteria like tuberculosis, non-tuberculous mycobacteria, septic emboli, or non-infectious etiologies as bronchogenic carcinoma and Kaposi sarcoma. But if it's diffuse infiltrate, we have either in a neutropenic patient who may have aspergillus, pneumocystis, cytomegalovirus. If we have humoral immunodeficiency, it's usually pneumococcus and Haemophilus influenza. If we have cellular immunity, like the HIV patients, we have pneumocystis, cytomegalovirus, mycobacterium tuberculosis, and non-tuberculous mycobacteria, nocardia, and so on. This slide illustrates the relationship in the HIV patient between the CD4 T lymphocyte number and the type of infection. So if we have here patient with 500 CD4, usually it's reactivation of tuberculosis or bacterial pneumonia. If it goes to 200, we have primary tuberculosis. Bacteria is usually not a pneumonia, but bacteremia. And if we go to the 150, we have pneumocystis pneumonia, cryptococcus, and non-tuberculous mycobacterial and cytomegalovirus. So the bronchoscopy in pulmonary infection, bronchoscopy is associated with diagnostic, have a risk in this patient population. So we should at first seek the non-invasive techniques before going to the bronchoscopy. And the diagnostic rate is usually 45 to 62 for infection as a cause of disease in the immunocompromised patient, and the complication rate is usually about from 0 to 49, usually desaturation, drop of FEV1, hemorrhage, and even death in rare cases. The protected specimen brush can be used in similar indication, but usually it has a little diagnostic yield to add to the bronchoalveolar lavage with a higher complication rate. So we usually, it's rarely used in our patients. Transbronchial lung biopsy carries an increased complication rate compared to BAL, was about 30%, which is mainly explained by the increased rate of pneumothorax with transbronchial lung biopsy. But we have to remember that early bronchoscopy to obtain a diagnostic sample is usually associated with lower mortality. So we should be prompt in our bronchoscopy once we need to diagnose our case. In patients with pulmonary infiltrates, in a patient who is immunocompromised and whom TB is considered unlikely, we usually do BAL only, and it's sufficient without any other further investigation. But in areas our population with high prevalence of TB, like Egypt, we add transbronchial lung biopsy, even if there is added complication, because it gives a higher yield in diagnosis. BAL or bronchial washing should be sent to the microscopy for acid-fast bacilli, for mycobacterial culture, in any case with pneumonia and immunocompromised, and post-bronchoscopy sputum is also should be tested for tuberculosis. Transbronchial lung biopsy and endobronchial biopsy for invasive aspergillosis should be avoided if we have the diagnostic test of BAL galactomannan, because this test give a high sensitivity and specificity, and because of the inherent risk, because patients with aspergillosis usually have a higher rate of bleeding and hemoptysis after biopsy. In patients suspected to have invasive aspergillosis, we should send also the BAL for microscopy for hyphae and fungal culture, and also for BAL galactomannan, as we just mentioned. So for this, this scheme was proposed by the British Thoracic Society guidelines. If we have an immunocompromised host with clinical suspicion of infection, and the less invasive methods are unsuitable or non-diagnostic, if the symptoms suggest tuberculosis, or there is an area of high prevalence of tuberculosis, then we should do both bronchoscopy with BAL and transbronchial lung biopsies. And all these investigations should be sent to fiber optic bronchoscopy for acid-fast bacilli. But if no, then the bronchoscopy with BAL are usually sufficient to diagnose bacterial infection in non-susceptible areas. Bronchoscopy in patients with HIV infection is actually of special importance, because the lung is the most common site of complication in HIV disease, and most of these are infectious. And the HIV itself increases the incidence of lung cancer by 3 and 5 folds. So HIV itself is a risk factor for lung cancer, especially adenocarcinoma. As the proposed theory is that HIV-induced release the apparent growth factors resulting in oncogenesis. So even if we diagnose by incident a case of adenocarcinoma in a young patient without knowing that he is HIV or not, we should retrograde screen this patient for HIV because usually he is positive or she is positive for this. And the prognosis is usually very poor for about from 4 weeks to 3 months after diagnosing of lung cancer in HIV patients. This violaceous rounded shadow is actually how it looks like the Kaposi sarcoma endoscopically in the HIV patient. By the way, the gross picture and the bronchoscopic picture of bronchogenic carcinoma in HIV patient is not different from the usual patients. So this is a case of non-small cell lung cancer. It's the same as other patients. This is a case of small cell lung cancer. This is how the endobronchial TB looks like. And this is a case of pseudomembrane of aspergillosis, also in HIV patient. The bronchoscopy in the other indication, which is in lung transplantation, maybe it's usually the only method to diagnose the allograft rejection in the lung transplant patient, but there is higher risk of bleeding, about 44% other than the normal persons, and the complication rate is also over sedation, pneumothorax, and hemorrhage. We do the transbronchial lung, we do the bronchoscope for lung transplant patients, not only for we do it for immediate and post-transplant in the operation theater, and as we said now, the diagnosis and surveillance transbronchial lung biopsy to diagnose rejection, for follow-up and therapeutic removal of sutures, dilatation, laser, electrocautery, and stent placement, and for research. Because sometimes we have granulation tissue at the place of sutures, so we use electrocautery or laser to remove this granulation tissue. This is how the sutures look like endoscopically in the lung transplant, and this is a placed stent after lung transplant. And thank you very much for your attention.
Thank you very much, Professor Mohammed Mtwali, and thank you for keeping for the time allowed. Last speaker in this session, مسك الختام, Professor Khalid Wagib, Professor of Pulmonary Medicine at Ain Shams University. Professor Khalid will talk about the bronchoscopy in emergency hemoptysis and foreign body extraction.
بسم الله الرحمن الرحيم. احب اولا اشكر الساينتفك والاورجنايزنج كوميتي، وشكر خاص للاستاذ الدكتور جمال ربيع، ربنا يشفيه. يمكن هنتكلم النهارده ان شاء الله على البرونكوسكوبي ان ايمرجنسي، ويمكن هنركز mainly على الهيموبتيسيس والفورين بودي اكستراكشن. البرونكوسكوبي is crucial for the management of emergency patient because of its usefulness in saving lives and also in diagnosis patient. And also it is safety even in a high risk situation. Emergency bronchoscopy indications طبعا a lot، نركز على الهيموبتيسيس والفورين بودي ريموفال، انما ليه انديكيشن تاني في الانتاكليكسيس والايروي اوبستراكشن والشيست تروما، وفي السي سي يو وفي ريسبيراتوري اي سي يو زي ما الاستاذ الدكتور طارق صفت اتكلمنا، وفي الاي ار وفي الاو ار. ماي توكس هير على البرونكوسكوبي والبرونكوسكوبيك موداليتيز في التريتمنت اوف هيموبتيسيس، وبعد كده هنتكلم على الفورين بودي اكستراكشن. زي ما حضراتكم كلنا عارفين الهيموبتيسيس ديفينيشن هو كافينج اب اوف بلاد اور بلاد سبيوتم اوريجينيتد لازم يبقى من اللور اير واي او من اللانجز، بيبقى على شكل اما بلاد ستريك او بينك سبيوتم اور فرانك بلاد. الموست كومن كوز هنعديها بسرعه برونكايتس والتي بي والبرونكيكسس والمايسيتوما والبرونكوجينيك كارسينوما، انما في انكومن كوز زي الميتاستاتيك والتروماتيك ايجنت بعد البرونكوسكوبي، وفي رير كوز زي الفورين بودي اسبيريشن. يمكن هنا السيفيرتي اوف هيموبتيسيس ما فيش يونيفورم ديفينيشن للهيموبتيسيس، انما يعتمد اساسا على الاماونت والرابيديتي اوف بليدنج والكارديو ريسبيراتوري ريزيرف عشان بتافكت الجاز اكسشينج، يعني اكشولي الافكت بتاع الهيموبتيسيس رادر ذان الاماونت. يمكن ده السكادول ده الابروتش للبيشنت وذ هيموبسيس ده انا باخد فول هيستوري تيكن وفيزيكال اكزامينيشن اكسكلود الفورس هيموبسيس زي الهيماتيمسيس والاي ان تي سورسز وبعمل الراديولوجي والروتين ورك اب وبعمل اسسمنت للسيفيرتي اوف هيموبسيس لو مايلد انترميتنت بليدنج بعمل الكتيف ورك اب انكلودنج سبيوتم وسيتيز واذر لاب انفستيجيشن وبعمل فايبر اوبتيك برونكوسكوبي الكتيفلي ولو وصلت استابليش للاتيولوجي بتريت سبيسيفيك ديزيزز وفي المودريت اكتفلي بليدنج لازم ادمت للبيشنت فور كونزرفتيف واوبزرفر ثيرابي بعمل برضه روتين ورك اب سبيوتم والسيتيز والاذر لاب انفستيجيشن وتريت انفكشن لو موجود والفايبر اوبتيك برونكوسكوبي والديفرنت موداليتي لو قدرت اوقف الهيموبسيس بتعالج سبيسيفيك ديزيز لو الهيموبسيس كونتينوس بحاول البيشنت ايذر فور امبولايزيشن او سيرجري. في الماسيف هيموبسيس دي تبقى كلينيكال ايمرجنسي بتادمت immediately البيشنت للاي سي يو وبنعمل له ريسسيتيشنز بي اي بي فلويد وايفن بلاد ترانسفيوجن وندي كاب سبريسنت وبوزيشننج لو انا عارف السايد اوف بليدنج بتبقى فيري امبورتنت وايفن بنبقى اسيست باوكسجينيشن واسيست فنتليشن ويبقى عندنا التولز المهمه والاساسيه هو الريجيد برونكوسكوبي بالسبيسيفيك كاتر وتيوب والانتراكيال دبل يومن والفوجرتي كاتيتر والديفرنت موداليتيز زي الواشنج والسكشن والكولد سالاين والدايليوتد ادرينالين والانترفنشن بروسيدرز بالليزر كرايو الكتروكوتري لو الهيموبسيس ستوب بنعمل الروتين ورك اب عشان نعرف السبب بتاعه والتريت سبيسيفيك ديزيزز لو الهيموبسيس كونتينوس بنحوله للامبولايزيشن او السيرجري. طب هل البرونكوسكوبي نسيسري في حالات الهيموبسيس؟ طبعا مهم جدا فور ايدنتيفيكيشن للسايت اوف بليدنج فور allow endobronchial management allow sampling من السسبكتد ليجن. which of which هل البرونكوسكوبي هنا هل فايبر اوبتيك ولا ريجيد برونكوسكوبي؟ اكشولي احنا عارفين الادفانتج بتاع الفايبر اوبتيك والريجيد كل واحد له الادفانتج وديس ادفانتج انما اكشولي احنا بنستعمل البوث في التريتمنت اوف هيموبسيس. ان دي بليدنج هنا من different sites من الاير واي due to different etiologies. البرونكوسكوبيك موداليتيز السكشن اولا لازم نحط البيشنت في اللاترال سيفت بوزيشن تو بريفنت الفلودنج اوف ذا كونترالاترال ان افكتد لانج وبستعمل ايذر الفايبر اوبتيك برونكوسكوبي يبقى لارج بور عشان جود سكشننج وبحدد البليدنج سايد ومهم قوي ان انا ريمبر عشان اقدر ارجع لها مره ثانيه وبعمل تامبونات اوف ذا بليدنج برونكس باي كونتينوس اور انترميتنت سكشنز ولو انا تكون لي بلاك كلوت ما بحاولش ان انا اشيلها. هنا الاذر موداليتي الكورد سالاين لافاج باي كورد سالاين اوف نورمال سالاين بالافريج بتاع حوالي 500 ملليلتر وده بعمل ايذر باي ويدجينج اور بارشر ويدجينج ودي قدر اللي هو يوقف البليدنج في اكتر من في ستاديز على 23 حاله وطبعا ده افويد النيد فور ايمرجنسي سوراكوتومي. another topical agent vasoconstrictor agent زي التوبيكال ابنفرين diluted 1 ل 20,000 طبعا افكتيف في المالد والمودريت بس زي حالات البوست برونكال بايوس او برونكال براشنج ونوت يوسفول في الماسيف بليدنج وبيبقى الهاي ليفل بتاع الادرينالين عالي فممكن يسبب لي هايبرتنشن وتاكاريزميا ففي اولترناتيف ايجنت زي التيرليبريسين اور اورنبريسين. another مود زي هنا الفايبرينوجين والثرومبين انستريشن اندوسكوبي الثرومبين والفايبرينوجين في البيشنت اللي هم waiting for bronchial artery embolization او even هم يبقى نوت سيوتبل ليها بالاول بعمل دراينس للاير واي قبل بعمل انجكشن لكومباينيشن اوف ثرومبين سوليوشن والفايبرينوجينز ودي ستاديز حقنوا فيها الميكسد ثرومبين اند فايبرينوجين وقدرت توقف البليدنج في موست اوف ذا كيسز ودي بتبقى تمبرولي ميجر قبل ما نحول البيشنت ل ايذر برونكال ارتري امبولايزيشن اور سيرجري. هنا انذر سيانو اكريديت جلو دي بايو كومباتبل ادهيزيف بتعمل سوليديفيكيشن اول ما تعمل كونتاكت بالهيوميديتي هي طبعا الجلو تيشو ده ويل نون في الفاسكولار والجاسترو انتستينال فيلدز الانجكشن في البليدنج باير ويز بتعمل اندوبرونكيال سيلينج. هيموستاتيك تامبونات ثيرابي بالاوكسيدايزد ريجنريتد سيلولوز ميش بتكنترول في هيموبسيس في بعض الاستادي من 56 من 57 حاله والبيشن ريمين فري هيموبسيس فور مور ذان 48 اورز وبتعدي من خلال الشانل بتاع الفايبر اوبتيك برونكوسكوبي وكنترول بليدنج في السب سيجمنتال والديستال اير واي انما نوت سيوتبل فور ذا ميجور اير واي. الاكلودنج الاندوبرونكال تامبونات هنا بنستعمل الفوجري امبولكتومي كاتيتر والتامبونات ودي بتبقى تمبرولي ميجر في الماسيف هيموبسيس قبل ما احول البيشنت للسيرجري. هو بيقلب على طول. بستعمل هنا ال4 فرنش في السيجمنتال وال14 فرنش في المين ستيم برونكاي ودي بتعمل توقف البليدنج في الاير واي لغايه ما اقدر تمبرولي ميجر قبل ما احول البيشنت للسيرجري. انذر تمبونات بالدبل يومن كاتيتر بالفريتاج، بستعمل هنا دبل يومن، دي ممكن تخلي البيشنت يقعد فتره اطول وافويد البليدنج، ولما بنعمل لها ديفليشن على الاقل 3 تايمز بير داي عشان البريزيرف الميوكوزال فايبيليتي والتشيك بليدنج بعد كده. ودي سكسسفل بليدنج في علاج 26 من 27 حاله كان البليدنج اكتر من 100 مللتر. lateralization possible not localization دي في اليونيلاترال انتوبيشن مهم قوي to protect non bleeding lung من الاسبيريشن. لو في الرايت سايد بحط الانتراكيل انتوبيشن الانتراكيل تيوب في الليفت سايد، لو في الرايت سايد ما اقدرش احطها بحطها في التراكيه وبعدي فوجرت كاثيتر عشان اعالج البليدنج من الليفت سايد. هنا السنجل اللي هو السبيجوت سيليكونز دي بتقفل المين اير واي لغايه ما البيشنت ترانسفير للسيرجري. الانترفنشن بالان دي ليزر ده افكتيف لو الفيزبل اند برونكال يومن وفي الفوتو كواجيليشن للتيومر وبتعمل جود هيموستيز، او عندنا ديفرنت مود تاني اللي هو نون كونتاكت الكترو كواجيليشن اللي هو الارجون بلازما كواجيليشن انذر مود، والالكترو كوتري في الدراي كونتاكت، واللاستري كرايوثيرابي في الاندوليوم اليومنال مالجنسي، انما ده ليه ديليت افكت فبالتالي ما اقدرش استعمله في الماسيف هيموبس. كنا هنتكلم بسرعه كده على الفورين بوديز. aspiration تبقى world wide health problem result from life threatening complication 2/3 بيبقى اقل من 3 سنين من العيانين. الاورجانيك ماتيريالز كومن الناتس والسيدز والبون، ده بقى الوايد رينج اوف كلينيكال برزنتيشن، وانما مش لازم ان انا اشوف البيشنت او يقول لي ان انا حصل له اسبيريشن، وخصوصا في الاطفال عشان كده ببقى هايلي سسبيشس في الاطفال للحاله دي. ما فيش ايمجنج ميثود بيبقى سيوتبل لانها معظم الفورين بوديز بتبقى راديولوسنت. البروكوسكوبي عشان كده هو الفريكوينت نيسيسري فور ذا دايجنوزس از ويل از ذا تريتمنت، ولو حصل ديليد للدايجنوز بيحصل الكومبليكيشن انريزولفد نمونيا والابسس والهيموبسس والبرونكيتسس ممكن تخلينا نحول العيان للسيرجري. الريجيد برونكوسكوبي هو الستاندرد، انما ممكن نستعمل الريجيد والفايبر اوبتيك، وطبعا محتاجين بروبر تريننج واكسبيرينس. وطبعا في الاول بنبتدي بالفايبر اوبتيك برونكوسكوبي لو قدرت اشيل الفورن بودي، بعد كده بحاول لو ما ينفعش بحاول استعمل الريجيد برونكوسكوبي، وخصوصا لو الفورن بودي امباكتد بجرانيوليشن تيشو. لو الفورن بودي طبعا صعب ان انا اشيلها بالريجيد سكوب وبالريجيد فورسز بستعمل الاند برونكال موداليتيز الاي بي سي الاند دياجليزر او كرايوثيرابي. لو الفورن بودي راوندد بستعمل الكاب فورسيبس، لو الريجولار سيرفيس بستعمل اليجيتور فورسيبس، وساعات استعمل الكرايو بروب نفسه باي ادهيجن واقدر اشيل بيه الفورن بودي. لو التراكيو برونكال دايمتر بتاعتنا نارو وما اقدرش ادخل الفورسبس، هنا بقى احط جايد واير باكستراكشن بالون بعديها من جنب الفورن بودي وبعمل انفليشن للبالون وبقدر اعمل ريتراكشن للفورن بودي واقدر اسحبها للميجور ايروي، وبعد كده بقدر اشيلها بالباسكت فورسبس عشان امنع الري اسبيريشن اللي ممكن تحصل لها في الاريا بتاعت السبجلوتيك لانها بتبقى فانل شيبد ونارو وخصوصا في الاطفال. يمكن دي في سيريز اوف ستاديز في الريموفال، وكانت نسبه النجاح بتاعتها من 61 ل 97%. يمكن دي اول اكسبيرينس بصراحه في عين شمس عندنا، ده ريترو سبيكتيف ستادي على مدى سنتين في 120 بيشنت سسبكتد كلينيكال سسبشن اوف فورن بودي اسبيريشن، 54 ميل و66 فيميل، والايدج من 3 مانث ل 70 سنه، انما 70% من الحالات اقل من 10 years. الفليكسبل برونكوسكوبي عملناها في 30 حاله، الريجيد برونكوسكوبي في 70 حاله، والكومباينيشن فيها 20 حاله، وكل الفورن بودي الكتيفلي ريموف من اول انترفنشن، ما احتاجناش نعمل سكند سيشن. الاناتوميكال لوكيشن للفورن بوديز هنا كانت الرايت سايد برونكال تري في 53%، الليفت سايد في 36 وده اليوجوال، والتراكيه 10%، ومعظم الحالات او اكثر من نصهم في المين ستيم برونكس. التايب اوف اير واي فورن بوديز اذر اورجانيك اور ان اورجانيك، انما الكومنز كان السكارف بين، وده طبعا بحكم ايه بلدنا. وفي السيدز وفي البينات وفي الفود ماتيريالز وفي البون واذر اوبجكتس. كان ده الفورن بودي ريموفال فورسبس، وده هنا البين اكستراكتد من خلال ريت برونكوسكوبي، وده شكل السكارف بين بعد ما شلناه. ده انذر بين هنا في الرايت لور لوب برونكس في الار بي 10. دي ديفرنت ميتاليك بوتون، وده هنا السنيلز، وده هنا الجراسبنج فورسبس. لما يبقى الفورن بودي راوندد كده بقدر ادخلها في السنترال هورد بتاعت الفورن بودي وافتح الفورسبس واخرج بيها مع البرونكوسكوبي. دي ديفرنت سيز اكستراكتد وبعضهم بفورسبس وبعضهم باي سكشن. دي another different shape of pain cover ودي common قوي في اطفال المدارس. ودي كانت النتائج بتاعتنا اللي على ال 120 اللي شفنا حوالي 111 برونكوسكوبي فيجوالز فورن بوديز وكان النجاح 99% قدرنا وعن حاله واحده بس كانت فيلد ودي حولناها لجراحه لانها كان لونج هيستري اوف اسبيريشن. 6 كيسز كان فيهم ميوكوس بلاج و3 كيسز ما كانش فيه فاوند فورين بوديز وما كانش فيه اي سيريس كومبليكيشن وما فيش اي ديسز. Conclusion: normal X-ray does not rule out foreign body. Bronchoscopy should be performed if foreign body aspiration is suspected because it is better to do a negative bronchoscopy rather missing a foreign body. Skilled pulmonologists can extract tracheobronchial foreign body easily and safely. Thank you.
شكرا جزيلا دكتور خالد. I do thank the chairperson speakers and may I call for the next session